IVM. Every day throughout your life, whoever you are, wherever you live in the World Health Organization is working to protect your most precious possession, your health.
Just like the United Nations, WHO is a waste of space. If after this pandemic the world didn't have a global health organisation like WHO, I doubt whether anyone would notice the difference. Just get out of our way.
Welcome to States of Anarchy, a podcast on global affairs and international relations. I'm your host, Hamsini Hariharan. For the last 6 months, we've seen how the coronavirus has slowly taken over our entire lives. There's a lot of political blame that's gone around, and the World Health Organization, or WHO, has seen a lot of it. The Chinese complained of racism and targeting, the Americans complained that the WHO was being too soft on China, and countries around the world argued that the pandemic should have been managed better. This is also the reason that Donald Trump announced that he was pulling the US out of the World Health Organization. On the other hand, Xi Jinping announced a $2 billion package for the organization. Now, I know you're wondering, why should India care? It should, because Dr. Harshvardhan, India's Minister of Health and Family Welfare, took charge over the WHO's executive board as chairman on May 22nd. Along with chairmanship, India also occupies 2 other influential positions in the WHO: the external auditor, which oversees WHO's spending between 2020 and 2023, and the chief scientist post, created in 2019 in response to requests of institutional reforms of the global public health body. So here are questions that the WHO will have to look at and that you should be thinking about as well. Why has global health governance failed to prevent the spread of such an infectious disease? How are global health priorities decided? What does the future of global health governance even look like? I shied away from discussing the coronavirus on this podcast because I am not an epidemiologist, and global health needs an expert who has a deep knowledge about the topic. My guest for today is no epidemiologist either, but she's possibly one of the most qualified people to ever appear on States of Anarchy. Dr. Sara Davies is a professor at the School of Government and International Relations, Griffith University, and an adjunct associate professor at the Gender, Peace and Security Centre of the School of Social Sciences at Monash University in Australia. Sara's work focuses on global health governance and the women, peace and security agenda. She wrote 2 books, Containing Contagion and The Global Politics of Health Polity and Legitimizing Rejection. She is the co-author of Disease Diplomacy, International Norms and Global Health Security. She's also edited multiple volumes and been published in more than 40 research publications. Suffice it to say, she's done some stellar work in global public health governance. Just a small note. We experienced some technical difficulties while recording this podcast, so there might be some parts that are slightly unclear. Don't let that deter you though, because we had a great conversation that we will return to right after a short break.
Hey everybody, welcome to another great week on the IVM Podcast Network. If you're not following us on social media, please do. We're IVM Podcast on Twitter, Facebook, and Instagram. I'd like to thank our sponsors this week, Paytm Money. It really has been a great week this week. We've had 2 of our first international cricketers show up, people who have played for their respective sides. We had W.V. Raman come on Edges and Sledges, the cricket podcast. If you haven't heard that, you should be listening to that if you enjoy cricket. It's really one of the best out there. And you should also definitely check out Monty Panesar, who showed up on Cyrus Says. That was another really interesting conversation that occurred. If you haven't been listening to a few of our shorter shows, please do that as well. Ashish Vidyarthi has been doing a great job for us. We got 30 episodes now on Begin the Journey. I think you really enjoyed that show. If you haven't listened to it, it helps you with understanding what's going on in this tough time and how to deal with it from a mental health perspective. We've also had some really fun stuff come up on the Smile India show. Shifa's been doing a lot of really good stories over there. Things would just make you happy, so definitely do check that out. And on the more serious side, make sure that you're checking out our regular shows like the Pragati podcast, All Things Policy. They're definitely going to keep you up to date on what's going on in this COVID world. And with that, let's get you on with your show.
Hi, Sarah. Welcome to States of Anarchy. Thank you so much for joining us.
Oh, thank you for the invitation.
So for, I think, most of 2020 now, we've all sort of survived under the shadow of the coronavirus, and we're continuing to do so. And you've studied pandemics and contagions before, right? So do you think this pandemic, the COVID-19, is unprecedented? How does it fare when we compare it to other pandemics like, the Spanish flu or SARS or MERS or Ebola or the whole number of diseases that have come before it? How is COVID-19 different, or is it different?
Thank you for your question. So I think it's really important actually to establish how does COVID, the disease that enters our body and the virus, the coronavirus, how does it sit against these other types of really big disease outbreak events that we may know of? So the 1918 influenza was sitting at a relatively high case fatality rate. So when we think about the last pandemic that had this really big impact across the world and affected large numbers of populations, irrespective of where they lived, we can see that we're really looking at the COVID outbreak as rivaling or being similar to that type of outbreak. What's been really important today compared to back then has been the speed of information that we've gotten out about this outbreak, the effort to try and change our behaviours to try and limit the fatalities, and then, of course, the really important advances that we've got in our public health systems and in our medical science today. Now, coronavirus is not like the Spanish flu, but it is a virus that sort of mimics the common cold. So it is one that is spread relatively easily, which is why we've seen these, unprecedented steps to try and contain it. Because if we look at one like Sars back in 2003, Sars had a higher case fatality rate. So more people would be expected to die from SARS if they caught it compared to COVID-19. But the difference is that it wasn't as infectious. So it didn't spread as easily. And so that's why we're seeing this effort to try and mitigate the spread of coronavirus, because it is quite effective at spreading. It's significant in terms of the death rate that it causes, and it's significant in terms of the hospitalization, so the type of care that people who get this virus require. So it can overwhelm health systems very quickly. So when we think about the type of pressure on the system, on health systems, and the type of fatalities, it is correct to compare it to the 1918 Spanish flu in terms of that type of impact worldwide on large numbers of populations and on health systems. But there are some important differences in our ability to respond today compared to back then.
All right, Sarah. So whenever we're talking about COVID-19, a lot of the blame gets placed on global health governance, and the World Health Organization, which is sort of at the helm of global health governance, faces a lot of this, particularly over the last 6 months. How do you sort of approach this idea of the WHO and how it's dealt with this crisis?
I feel that the blame that's been apportioned to the World Health Organization is somewhat unfair. The World Health Organization is the international body that we turn to for advice on how to manage an outbreak, so how states should respond to an outbreak, what is the best testing procedure, what is the best reporting procedure, and what sort of social distancing measures should be introduced in the society. The World Health Organization can only provide that information if they've got access to reports from states. And if states aren't providing that information to the World Health Organization, letting them know what numbers of cases they have in their country, the testing ratio, and this sort of detail, then the World Health Organization is working blind.
Yeah.
And I think it's fair to say in January, we did see the World Health Organization needing more information and struggling to get it.
Yeah, I was reading this article about how the World Health Organization did get a lot of flack, particularly for being too soft on China or pandering to Chinese officials. And I read this article recently, I think, from AP, which was talking about how there was, even if the World Health Organization officials were praising the Chinese and lauding them for their efforts, there was also a lot of dissatisfaction with the amount of data that the Chinese government was willing to give them. but it's also received flack for not recommending travel bans or criticizing them in parts of the world, and other such actions as well.
And this is the dilemma that the World Health Organization faces. Does it name and shame countries and risk or hope that those countries then will cooperate? Or does it name and shame countries and has to then bear the consequences that that country will withdraw information? And I don't think anyone could say with certainty that we know which way it's going to go. So if we go back to January, while the World Health Organization could have come out and publicly stated that China wasn't providing the information that they needed to give advice to everyone else, it's a big risk, right? To then assume that China at that stage will feel shamed and just comply. Because we look back now and we know that this was a serious outbreak that spreads very easily in communities and has a significant case fatality rate. But back in January, we didn't all know that for sure. And so it would have been hard for the World Health Organization to make that call. And so they decided to go with the softly diplomatic approach. And like you, I read that article, and we now know that when Tedros, the WHO Director General, Ghebreyesus, and Mike Ryan from the World Health Organization flew to China within 24 hours, that was, a face-to-face meeting to try and get the Chinese government to realize that this was serious and they really needed that information. So the idea that the World Health Organization wasn't aware of what they were doing, or that the softly approach was sort of this duplicitous attempt to try and get China on their side, I think they would argue this was diplomacy, and this was our attempt to try and make sure we got as much information so everyone else knew what was going on. Because the World Health Organization could argue in response that, who else was going to get this information from China? I think where perhaps the World Health Organization maybe went a little bit too far, it might be fair to say, was some of the press conferences where we had glowing discussion about the way in which the lockdown was handled in Wuhan City. I think that started to raise a few concerns that it seemed that the effort to try and bring China on side was going a little bit too far. And I think that's when alarm bells started to ring. Fair or not, but that was when alarm bells started to ring.
Yeah, and I think the other thing that also came up was sort of, whether Taiwan should be a part of the World Health Organization. And then there was, sort of this viral video where I think a reporter from Hong Kong was talking to an official from the WHO, and she asked him a question about Taiwan, and he hung up, and then it was a very funny video to watch.
Yeah.
but yeah, I guess
I watched it too, and when I saw Bruce Abel do that, I was like, that's not good. You knew straight away.
Yeah, but it's also, one of my deepest fears. I'm always afraid that, if I'm going to ask you that question, then you're going to be like, yes, we've already discussed that. Let's move on to the next step. But taking a step back, to global health governance and looking at sort of the role of the WHO, they were formed 70 odd years ago, and they've taken sort of the principal lead in a lot of global health issues. How do you think that the structure of the WHO and their mandate has evolved over the last 70 years?
On the one hand, I would say that the World Health Organization has done an incredible job trying to hold it together, particularly during the Cold War, when you had an organization that was set up to have a headquarters in Geneva and then a number of regional offices located around the world. And these regional offices had their own budgets and their own agendas. And then the headquarters also had its own budget and its own agenda. And then you also had this big rift down the middle of the World Health Organization around, should it be providing advice on how health systems should be managed and what states should pay for in terms of universal healthcare coverage. And then another group arguing that, that the World Health Organization is there to just provide technical advice. It's not a normative agency. It's not about telling us what is the best way to look after people's health and what sort of system the state should put in place. It's just there about measurements and technical advice and making sure that the best information on vaccines is coming out. And so it's had this really tight sort of, and that's affected its budget, and that's affected the way in which the United States and the United Kingdom, and then increasingly now China and even India, the way in which these very important states with big populations have thought about health and thought about what is the role of the World Health Organization in providing advice to them about what is best practice. And so we see that sometimes where the World Health Organization gets things right would be, in the smallpox eradication campaign, and the effort to try and bring states together, irrespective of conflict or different political regimes, around an issue that everyone agrees, it is important to try and eradicate it. Where we see the World Health Organization then reach difficulty and controversy at times is when it tries to promote particular agendas that different states have really different views on. And so the classic one in the past has been universal healthcare coverage, where you've got different states with very different positions on what the state should be funding and what individuals should be paying. And so I think where we see most trust, though, so after back in 2011 and then again in 2014, there were some really interesting efforts to try and understand what states trust the World Health Organization to do. And one of the things that came out of those surveys was there's immense trust in the World Health Organization to manage and coordinate infectious disease outbreaks. And it'll be interesting to see if that survey could be done again now, how the World Health Organization is traveling.
Yeah, that would be a fun survey to redo. And I think a lot of this also goes back to the fact that you think that health is technical, that it's a matter of science. But when you really break it down, whether you look at COVID or maternal mortality or AIDS or any of the things that happen, a lot of the issues of health are also social, they're also political, and you sort of can't divorce the two. So I think that's also something that you have to consider whenever we're talking about what global health governance looks like, right?
Absolutely. And this is where I think after the Cold War, there was this sense that the United Nations institution as a whole would be able to think about how to address big social problems, or what at the time was called these themes of human insecurity, and health was identified as one of those that, we've now gotten through the Cold War. Those types of communist and capitalist divides kind of come to an end, and we now need to look at what's preventing human development. And health was one of those identified back in the 1990s as an area that we should all be able to cooperate towards. And I think you're right. What we've seen with the Millennium Development Goals, and what we've seen even with the Sustainable Development Goals, to which the World Health Organization has been a part of, has been there's still some rifts there. There's still some significant tensions, as you say, because to improve some health inequalities, we have to also address other areas like gender inequality. We also have to address things like, massive income inequalities. We have to think about, do we want what is our position on generic drugs? What vaccines, families should pay for, and what vaccines should they receive for free? And those types of practical sort of or structural issues around what we set up in our society and what we value then also do affect then what choices individuals have to improve their health. Because if they don't have, if a woman cannot access contraceptives, or if a family have to pay market price for, an MMR vaccine, that's going to really affect then the progress that country can make as a whole in the area of health.
And you've written extensively about this, but I think that's one of the reasons why the international health regulations were reformed back in 2005, right? After sort of decades of deliberation about what the WHO was supposed to do. Do you think this sort of reform of international health regulations is going to continue?
Yeah, so the international health regulations were originally agreed to be revised in 1995. There'd been a number of disease outbreak events where countries either didn't report what was happening, or they did report the outbreak was happening, and then there were these really harsh travel and trade restrictions applied to these countries, which affected them economically, but also affected them at the human rights level. So, if you traveled from a country that had a cholera outbreak or a plague outbreak, you weren't allowed into countries because they saw you as being infected with these diseases. So there were all kinds of random barriers that were happening that people were experiencing. So there was a decision made in 1995 at the World Health Assembly that these international health regulations, which were adopted at the time that the World Health Organization came into effect in the early 1950s, needed, in 1951 to be precise, needed to be revised. We needed to get states to report outbreak events when they were happening without fear of trade and travel repercussions. And we need to get states, when an outbreak announcement is made, to follow the advice of the World Health Organization. And so the next number of years, they were trying to figure out as a group, so at regional level, but also back at headquarters, what would states agree to? Do we go for a list of specific diseases, or do we go for an algorithm where we have a couple of events? So, the disease is spreading, we don't know where it is. So we've got, like a matrix that we follow through to decide whether or not a country should report this outbreak to the World Health Organization. And then SARS happened, and that changed everything. So what had been, years of debate, all of a sudden you had a real live outbreak happening on your hands. No one knew what it was, and it seemed to be spreading relatively fast, and it had a significant case fatality rate, especially in healthcare workers. And so the WHO Director General at the time, Gro Harlem Brundtland, basically said, we need to just get this international health regulations revised as quickly as possible, and we need to take into account what's been happening in SARS and take SARS as the example of what we need to respond better next time. And so in 2005, the international health regulations were adopted, and I and a few others have argued that without SARS, I don't think you would have gotten those regulations adopted as quickly or even as with the breadth and depth of the revisions as what they had. So, there was implementation in those revisions around states must report within 24 to 48 hours of a novel outbreak event. They must confirm back to the World Health Organization what the outbreak is. Non-state organizations can report outbreak events direct to the World Health Organization. There were specific states are not to implement trade and travel restrictions without following the advice of the World Health Organization. And then the WHO Director General themselves can declare an outbreak as being a public health emergency of international concern, which is what happened with the coronavirus outbreak earlier this year. And that's different, I should add, to declaring something a pandemic. This is about saying that this is an outbreak of international concern, so states need to then adopt and show that they need to report back to WHO on these cases, and they need to show that they are complying with the recommendations that the World Health Organization issues around this particular disease. Now, what's happened with the coronavirus outbreak has been states have done their own thing around trade and travel recommendations. So the World Health Organization wasn't actually recommending specific trade and travel recommendations, but states started doing it anyway. As I said, Vietnam immediately implemented travel restrictions into its borders from China. And a number of other countries implemented travel restrictions from flights coming from China. And that was without the recommendations of the World Health Organization. And there's a lot of discussion now about, can these regulations provide trade and travel advice in the future? Because we've just seen so many states in this outbreak just take matters into their own hands. And if that can't be upheld under the regulations, then what other bits of the regulations will states pick and choose that they want to agree with and implement? So there are a lot of questions at the moment about the strength and the durability of the international health regulations after this outbreak. But I'm one of those who argue that the international health regulations were so much more than just trade and travel regulations, and we need to keep focus on that as well.
Yeah, I think, if SARS was sort of the reason for the regulations to get reformed, then COVID-19 has really been the litmus test for them in a sense. And I'm really wondering how the future sort of looks like for this reform, because recently you have Xi Jinping agreeing to provide the WHO with, I think, about $2 billion. And at the same time, you have Donald Trump saying that he was going to pull the United States out of the WHO. And this is very interesting for me as an Indian, because I just found out that India has assumed leadership of the executive board of the WHO. So how do we sort of see the future of global health governance play out? What do you think we should be watching out for?
So I think what will be important to see is that the World Health Organization is going to be financially under a lot of difficulty if the United States does follow through and pull out altogether and the funding is removed. And we're seeing that's most likely going to be the case. And China has offered the $2 billion injection of cash, but that's still not necessarily, we're not entirely sure what that injection of cash will be in. Will it be in specific programs that it wants the World Health Organization to focus on, or will it be in the operating budget of the World Health Organization? And that's the issue with the World Health Organization. It's got two budgets. It's got a budget that allows it just to operate and to hire people at headquarters and work 24 hours, 7 days a week, tracking this virus, as well as loads of other health-related programs and provide information on. But then it also has got very specific programs that it's providing expertise and advice on to countries. And so we're not quite sure yet at this point how this is going to play out. I think the entry of India into the World Health Organization is significant politically, because I think it's fair to say that China has seen technical agencies within the United Nations, like the World Health Organization, as an area where it can be influential and where it can present its power. You know, it has been quite ambitious in the area of health diplomacy now for a good 5 or so years. It has been seeking to provide health scholarships along to countries that are part of its Belt and Road Initiative. It sees itself as having quite a positive story to tell in terms of health development within its own country. And it has been seeking to expand its representation in other health-related areas, such as vaccinations and drug development. So I would say it's quite significant that India is seeking entry into the World Health Organization, particularly management of the executive board, because India also has quite a strong record here in terms of the pharmaceutical industry and itself seeing it as having quite an important technical role in the area of vaccinations and drug development as well.
Yeah, and I'm just wondering, because we're looking so much at, as you mentioned, the pandemic has really revealed sort of all the existing inequalities that are across the board. And all pandemics do that, but this pandemic particularly. And what I'm wondering is the relation between how we look at health as a matter of national security. And do you think that more countries will look at sort of the securitization of infectious diseases, and it will command more space on like global health agendas? What do you think of that?
That's what I'm not sure of at the moment. So when I said before that it's important with the international health regulations that we don't throw them all out altogether, I think there are some areas that we need to see that there has been a surprising degree of cooperation in, with some exceptions. So we see there has been efforts to try and get information shared around testing. There's been efforts to try and get information out in terms of the case fatalities. There's been efforts to try and develop some sort of cooperation around vaccines. Even though there's rivalry there definitely is. And I don't think we should shy away from that and the serious implications that could happen depending on who comes up with the vaccine for COVID-19. I think there has been efforts from Japan to Germany to South Korea, as well as, you know, I think it's important to note that even, you know, China and Russia have been participating in these types of discussions, as well as the United States has been present, but not always participating. So there has been an effort. There is this realization that there still needs to be some kind of global discussion taking place. I think where there's been disappointment is, of course, and where I think it is fair to say that the absence of the United States from this space does seem to have had an effect on the type of cooperation and coordination that we saw if we look at what happened with the Ebola outbreak in West Africa in 2014. It's fair to say that the United States at the time was quite a key player in making sure that that outbreak, once everyone decided that there should be a response to the outbreak, the United States was quite influential in getting the economic and political response coordinated to deploy the mission that was, the UN mission that was deployed there in response to that outbreak. So I think what we're going to see here is not necessarily these types of ambitious new agendas or these ambitious types of diplomatic coordinations. What we're seeing is more areas where we can identify technical cooperation, areas where we can identify and facilitate exchange of information. And that to me is going to be because, as you say, it's areas where the cooperation or the information can support our sovereign response. So we're still seeing the protection of our own health security, the promotion of making sure that our populations get access to PPE, personal protective equipment, that our population will get access to vaccines. This is sort of uppermost in every state's mind, even those states that maybe are responding very slowly or denying its existence. They know at some point they're going to have some response. And so there's sort of this holdback at the moment, I think, on these sorts of big global cooperative endeavours, because I think everyone's still waiting to see just how this disease spans out. And so I think it's fair to say that national health security is still taking priority for a lot of countries, even those countries such as that are part of the European Union. You're seeing different members enter into regional arrangements there at different rates because there's this effort to try and understand how will these types of multilateral cooperation affect their ability to respond domestically. I don't think this means the end of international cooperation as we know it. I think we're in a phase at the moment where it's a bit different to how some of us would recognize it from the past.
Mm-hmm. And I think on that note, it's also interesting that you brought up PPEs and masks and things like that, because there has been a lot about disease diplomacy during the pandemic, right? You have China saying that it was sending huge numbers of doctors and PPEs to other countries. Then there were a lot of questions about, whether it was sending these out of goodwill or whether it was selling them to these countries. And there was a lot that was reported about disease diplomacy. And as you mentioned, particularly about how the United States did not sort of take a lead role in this. So from that point of view, what do you think about how different countries have played this out?
I think it's been significant to see China actually being quite aggressive in this space, where they're calling it now mask diplomacy. But we see on the other hand that there's been, a little bit of pushback on that as well, in the sense that, that maybe some of the supplies that they provided were not of the standard required to prevent the spread of infection. But even then, there's politics wrapped around the rejection of those types of aid goods as well. I think also what's interesting about the PPE and the mask diplomacy has been the sense that it is something that states do or can do when they feel like they've got a hold of the needs within their own domestic situation. So it's been significant to me to see that you've had South Korea and Vietnam, for example, take very progressive steps in providing masks and supply and production to different countries. And that's, I think, a statement of the security that they have within their own country in managing their response, and also the degree to which they are confident of the supply that they have within country. So there's also been, for me, an interesting sort of development here where the actors that we would normally associate with being the generous aid benefactors are actually the ones in this instance that are not generous. So the United States has been a classic example where we've seen a number of instances where there has been attempts to try and prevent the supply of PPE equipment to other countries and prioritize their own needs. And I don't think that will be forgotten anytime soon, to be honest. I think it's going to haunt the United States, some of the actions that they've taken in this instance. But then I think what's also been interesting, and this is where a little bit of time, I think, will help us understand what's been happening. We also know that in the case of Europe, that there was a lot of controversy about when Italy issued its calls for help through EU and help did not come, and there was a number of weeks there where there was a delay, and China did respond. That there was also at the same time there were responses eventually that came from Germany and France in particular, and there's been apologies since then about the delay in that response. And there's been an effort since then to try and ensure that there is not that delay again, and that there's been a lot of effort to make sure that there is a sharing of intensive care units through, transporting patients across the countries to manage the burden on hospitals. We also see in the Association of Southeast Asian States a similar sense that in the March there was a little bit of delay there in terms of getting the regional organisation together to provide a collective statement on how they were going to support states of very different capacity in response to this outbreak. And since April, we've seen a step up in the various sectors of ASEAN trying to demonstrate that there is a united front. So I think regional organisations have maybe been found to be a little bit slow. But then I think what's been interesting actually has been the African Union. From what I've heard in terms of all reports and accounts, has been that they've been quite rapid. And of course, that's because they've had now for a number of years to manage and coordinate a number of infectious disease outbreaks that they've had, from the Ebola hemorrhagic fever as well as the measles outbreaks that they've had in some countries. So it's also interesting to see the regions that have a certain amount of robustness in response is because they've been having to practice this response over a number of different times, a number of different events throughout the last couple of years.
Mm-hmm.
So it's not always about income. And I think that's what for me has been interesting with this. We talk a lot, the way in which we talked about development, the way in which we talked about cooperation in the past was about, political regimes and income. And I think what we're seeing again with coronavirus is while those things can make you vulnerable, there are also other unexpected areas that can also make you very strong in response, that can make a state very strong in response. And I think that's also, again, something for us who try to make sense of these things at a macro level to take into account now, that it may not always be regime type, it may not always be income. There can be other factors that are really important in how a state responds to emergencies.
Thank you for that, because this sort of drives to something that we talked about before we started this recording, which is, how the pandemic has sort of affected women differently. And I think we spoke earlier about how health priorities are often determined based on different factors for countries. And I'm always interested to see how it's affected women, because women's issues, particularly in health, have been easily overlooked. And I was reading an article that you wrote recently, which called the WHO to adopt a feminist economic agenda. So what would that look like, and how would that sort of tie in with health reform or whatever we're going to see in the future?
Thank you. So that was a piece that we wrote just before actually the coronavirus outbreak. And it was after an individual, a couple had written a piece saying that that the World Health Organization needs to engage with the economic agenda, that if we're going to make the case for investments in health, we need to think about it from the economic benefits. And that needs to be paramount in the way in which they think about budget reform and expanding their programs. And for Asha, Hurton-Crabb and myself, what we thought about that was, we know that some economic positions, if you think about some of the neoliberal programs that have been run and supported by economists, can actually be quite detrimental to health outcomes. It can really have dire consequences if you are told that the state is going to introduce user pay systems, that the state is going to no longer provide, sort of a base rate for healthcare workers in terms of their guaranteed income, that it's going to be competitive pricing, and that there's going to be the transfer of a lot of public health sector to private sector. And so for us, it seemed really important to introduce the notion that not all economists are on the side of universal healthcare coverage and on the side of health as a human right. And for us, what we wanted to argue in that piece is that if you think about the health economics from a feminist perspective, you're going to be thinking about the fact that a lot of our healthcare provision is by healthcare workers who are mostly women. So 70 to 75% of our healthcare workers are women. and a vast majority of them are on low incomes, and yet they are every day doing really important, vital work that are keeping people alive. And we said the other thing that needs to be thought about is the way in which we question and what we know. So we were saying, you know, if you think about the fact that we still don't have very good data on violence against women, so it's very hard to actually understand across the world how women's experience of violence then affects their access to a range of other different types of services. So if women are under fear of experiencing violence or are experiencing intimate partner violence, it can affect their children's access to education, it can affect their access to income, it can affect their health outcomes, it can affect the level of agency that they have in their family, which can also affect the types of income decisions and healthcare decisions that they can make for themselves and their children. We also argue that what's really important to then think about this as well from this perspective is all the things that then we don't know. So if we've identified the fact that we've got a large number of healthcare workers who have access to populations every day who are women, but don't have access to the civil and political space, so they can't feed that knowledge that they have back into policy decision making. If we have large numbers of women who are not able to exercise autonomy over their income and over their healthcare decisions, then there's a lot of assumptions that we're making about how people access healthcare and how they make decisions about healthcare that are mostly from the perspective perhaps of men or from the perspectives of women who are not in these types of situations. And that's mostly elite, well-educated women. And so there's a number of populations who we may not be capturing with good understanding about the impediments that they experience in terms of seeking healthcare, but also the ways in which they manage and survive on a daily rate. And we should be paying more attention to those sorts of experiences. And we argue that feminist economics asks us to look for the data that we don't have, to think about the populations who manage our political economy every day and do so without the same levels of equity and financing that your big institutions and your capital land might have. And so we argue that then would change the way in which we think about healthcare programming, and it would change the way in which we do research and the way in which we build evidence to make the case for what we should fund and what we shouldn't fund.
You know, that's extremely interesting for me because particularly as I live in India, when there's so much unpaid work that's here, I mean, as there is in the rest of the world, you can sort of see that the amount of care that women have to put in, particularly through this pandemic, has soared. And the other thing that was very interesting for me was the lack of access that women, trans people, and a lot of LGBTQ people had to drugs, particularly for AIDS, for contraception, for a lot of different diseases. And it was building on all the existing systemic inequalities that we have. And it's also very related to feminist economics, because I think whenever you have giant economic shocks like this pandemic is going to set off, you see women and immigrants sort of being the first ones to bear the brunt of that. And therefore, I think it is very important that in the future we sort of take a feminist economic agenda.
Yes, I mean, I couldn't have put it any better than what you did. But I think the way you phrased it is perfect. But I agree. I think for me, with the coronavirus outbreak, what we're seeing is the inequality of our economies being magnified. So when we think about who do we rely upon to do the care at home of children who cannot attend school, of caring for people who may be most vulnerable to this outbreak, who are we relying upon to do a lot of the healthcare working tasks? In some instances, a lot of the cleaning tasks of hospitals and of the facilities, as well as a lot of the first pick groups to lose their jobs, to be furloughed, were women in all of these instances. So we've been looking at, I'm part of a group with the Simon Fraser University that's been funded by the Canadian Research Council to look at some situations where the coronavirus outbreak first occurred. So we're looking at China, Canada, Hong Kong, the United Kingdom. And we're looking for areas where gender seemed to have a big impact on the way in which health system, economic systems, and legal systems responded to this outbreak. And we're seeing some themes across these very different cases, which is quite remarkable and which tells us the way in which our states are set up to support women and men and support gender norms are very different. So we're seeing that there was high levels of intimate partner violence during the lockdowns that a lot of governments weren't able to anticipate and respond to quickly enough. So there was that underlying current of domestic violence in our societies that really came out in massive numbers when people were forced to stay at home. There was a high number of women who lost their jobs or had to give up their jobs in order to provide the care at home roles. And that was irrespective of where we're talking about. That tended to be a trend that we saw across. There was a surprisingly high number of, across these countries, of healthcare workers, mostly women, expressing high levels of anxiety about how they were going to access their care and their needs. So, if they're in lockdown, how are they going to be able to access, their sanitary pads that they may need while they're on long shifts, or if they're having to be placed in hotels during the peak of the outbreak response. And there was a sense that these types of needs that are particular to women were not accommodated or thought about in the initial phases of the outbreak response. And then the other thing that we found as well was that there was a high degree of expectations that someone would be at home to do the caring, and that most of those people who would be doing the caring would be women. And yet a lot of the economic responses that we saw come out in the first couple of months was mostly about JobKeeper programs, thinking about how to provide welfare programs for people who'd lost their jobs. But the way in which the cutoff dates were introduced, a lot of the women who were most affected in the early stages weren't accommodated into these types of programs because they'd already made choices about cutting their hours or in some drastic cases not going to work because they had already began to anticipate the impact of the outbreak on what work they could and couldn't do. And then food insecurity was another thing as well that we thought was really interesting, where there was a high numbers of reports about women mostly being very concerned about being able to afford food and being able to access food. And now we don't want to go into gender stereotypes here and say men only care about this and women only care about that. But I think what's important to note is that our societies do seem to have still these very strong norms around what women will care about, what men will care about, what women do, what men do. And then that then affects your ability to respond to this outbreak with a degree of autonomy outside of those stereotypes. So, in an outbreak, there's even more limits in terms on how you can challenge your social norms, on how you can defy them, because it's an emergency, right? So you've got to just do what you've got to just respond in that moment to the events as they occur. So we found that women's power and agency also tended to diminish in this outbreak as well. So their chance to be able to voice dissent or be able to articulate what impact this was having was also being constrained as well. So that's an ongoing study that we're doing, and we're very keen to develop that. And we've got a matrix up on the website, and we want people to take that matrix and apply it to different countries and try and see if they use the same methods. What debates can they see were happening in their societies? Because we think this is really important for recovery as well. We're already talking about the economic consequence of this outbreak are going to be enormous. And the concern, right, is that if you have situations where mostly women are in low-income jobs, mostly women are in positions of economic vulnerability, particularly female-headed households are in social and economic vulnerability, this outbreak has just magnified that and has prolonged it. So it could have intergenerational consequences. So it's really important that we get a grasp on it and understand what's happening so that we can advocate for economic and policy responses that address the potential of widened gender inequalities after this outbreak.
I think those are really good points, and I really look forward to seeing how this project turns out. Sara, this is my last question for you. what books or resources would you recommend for people who are interested in knowing more or reading more about global health and global health governance?
Thank you. So I think it's really good to do one on the history, one on a previous outbreak, and one on the governance. So for me, the one on the history, I think Pale Rider by Laura Spinney is perhaps the most contemporary examination of the 1918 Spanish influenza outbreak. And I think what's interesting about that book is that it tries to think about the history of science and also the history of response at the time. So it's written by, she's a science journalist, and so it's very easy read and it's very interesting. And you will keep reading it and thinking about how it echoes or contrasts with what we're seeing today. Another book that I think was really important to read is The Politics of Fear, and that's by Michelle Hoffman and Soking Wu, and that's on the Médecins Sans Frontières response to the Ebola outbreak in West Africa in 2014 and 2015. That's an edited book, and it's got a lot of different perspectives in there, from anthropologists to first healthcare responders to the outbreak. And I think what you get when reading this book is a really good appreciation of the way in which your different actors respond to an outbreak, the agency that some people have and some people don't have in being able to socially distance or in being able to exercise some degree of autonomy when they may be a healthcare worker, but they're working mostly in a voluntary capacity and they are reliant on having a job after the outbreak, and how they question authority and sometimes don't question authority. And that has a big impact then on how you can respond to an outbreak. So that's one that I think is really important to read, because we were talking before about different states have different ways in which they've responded to this outbreak. So this one gives you a really good feel for that. And then I think another book that's really good to look at the moment when we're thinking about governance, and particularly because we're going to be entering the phase now of having to think about how we're going to respond to this new governance problem of cooperation, would be Jeremy Yude's book on global health governance that's been published with Lynn Renner. And he tends to focus a lot on the United States. You seem to have still these very strong norms around what women will care about, what men will care about, what women do, what men do. And then that then affects your ability to respond to this outbreak with a degree of autonomy outside of those stereotypes. So, in an outbreak, there's even more limits in terms on how you can challenge your social norms, on how you can defy them, because it's an emergency, right? You've got to just respond in that moment to the events as they occur. So we found that women's power and agency also tended to diminish in this outbreak as well. So their chance to be able to voice dissent or be able to articulate what impact this was having was also being constrained as well. So that's an ongoing study that we're doing, and we're very keen to develop that. And we've got a matrix up on the website, and we want people to take that matrix and apply it to different countries and try and see if they use the same methods. What debates can they see were happening in their societies? Because we think this is really important for recovery as well. We're already talking about the economic consequence of this outbreak are going to be enormous. And the concern, right, is that if you have situations where mostly women are in low-income jobs, mostly women are in positions of economic vulnerability, particularly female-headed households are in social and economic vulnerability, this outbreak has just magnified that and has prolonged it. So it could have intergenerational consequences. So it's really important that we get a grasp on it and understand what's happening so that we can advocate for economic and policy responses that address the potential of widened gender inequalities after this outbreak.
These are great. I'm going to definitely add them to my reading list. Thank you so much, Sara. Thank you for taking the time out to speak with us, and best of luck for your projects.
Thank you.
That's it for this episode of States of Anarchy. Thank you for staying with us. I've attached links to some of Sara's work and the books that she's recommended on the episode description, so do check those out. If you have any comments or questions, you can reach out to me at Hamsini H on Twitter and at States of Anarchy on Instagram. If you want to learn more about foreign policy and international relations, then check out the policy courses and the research from the Takshashila Institution. They do some really cool work. You can listen to States of Anarchy not only on the IVM Podcast app and website, but on Spotify, iTunes, Savan, Ghana, or wherever you get your podcast from. We'll be back on the 23rd of May. Happy listening.
Namaskar, this is Ashish Vidyarthi. Yes, my friend, these are challenging times, but in these challenging times, we can create something extraordinary. Do take time to listen to my podcast, Begin the Journey. Available on the IVM Podcast, website, app, or wherever you listen to podcasts. Remember, we have a great opportunity called life. Cheers.
Hey everybody, we have a brand new podcast series by Bloomberg Quint called BQ Conversations, which covers a range of topics like business strategies, latest trends in technology such as cybersecurity and artificial intelligence, and also personal finance. Episodes are out on the IVM Podcast app or wherever you listen to podcasts.